Can I record? Oh yeah. Okay, perfect. I'm good. Okay, I just wanted to make sure.
Yeah, and I'm recording it on this end, but it's paused currently.
Okay. Yeah.
Enteric fractures, and both performing and radiographically assessing fracture reduction. And so I hope that this is interesting. I want to make it relevant from the very beginning. So here is your case. So you have an elderly patient that comes in with this pertrochanteric fracture. There's an AP and a very mediocre lateral as usual. And I want you to think which pieces are displaced and how are they displaced, which reduction maneuvers will you plan to use, and once you use those maneuvers, how are you going to judge whether your reduction is appropriate or not? All right, so my interest in this, at least in part, stems from the AO and through work that was done by a working group on trying to understand both imaging and fracture reduction when it comes to pertrochanteric fractures. Some of you may have seen these in your operating rooms. I know that they sent some out in an effort to do a research project on whether trying to define standardization for both radiographs and reduction would help in proximal femur fracture fixation. We're going to talk about some of the things that you see here, and I'm going to go into a fair amount more detail about it so you have some history behind it. All right, so at the end of this hour, you should be able to clearly define 4 population average or normal radiographic parameters for the proximal femur, and to state at least 4 objective reduction parameters in pertroch fracture fixation and when you're going to use which one. But I want to make it clear from the very beginning, this was a complicated project. Did any of you faculty that are on the call have those posters in your ORs? Were any of y'all involved? No? Okay, good. So the residents won't be as familiar with it, so I think that might be helpful. So what's complicated about this is there are 3 variables, and it's very hard to control them. So there's the variable of the radiographic beam and the position of that beam. There's the variable of leg position or fragment position when we speak of pertrochanteric fractures. And then there's the variable of patient anatomy in general. And so we're going to cover these a little bit. Our assumption right now, though, for these objectives is that we are standardizing the beam and the leg position, and this patient has normal anatomy as we go over defining normal or population average radiographic parameters. All right, so this is a picture of one of my mentors. For those of you who read the article that I sent out yesterday, it was something that I'm not sure if he ever read, but I think he thought very similarly to that anthropology professor. And so, you know, when I had the opportunity to do an AO fellowship and work with him as a 3rd and 4th year, that's when I met Tom for the first time. And it's also when I started to draw. I'd never considered myself much of an artist, still don't, but he challenged me and said, you need to have a better understanding of what you're treating, and you're just kidding yourself if you think you got it. Your gestalt is not good. And so I want you guys, those of you who are willing to sort of put yourself out there, I'm not going to make you show your drawings, but get out your pencil and paper, and I want you to draw an AP hip x-ray. I'm going to give you about a minute or so. It's almost a little unfair that you have the opportunity to see some of these pre-op plans. I think that's going to help your drawing be significantly better than what it actually would have been had I not given you that. The complaint that I typically get when I ask people to do this is, well, just because I can't draw doesn't mean I don't understand what I'm looking at when I look at an AP hip x-ray. And I would agree to a certain extent that could be true, but what I find about myself, if not other people, is that when you think your gestalt is educated, you get fooled. So the only way to get better at understanding what you're seeing is to be able to clearly delineate exactly what it is in terms of shadows and lines, white space, if you will, relationships. All these things are things that artists think about that we don't think about very often, or at least most of us don't think about very often. All right, so you should have an AP hip x-ray drawn. So how much did it look like this? So on the view to the left, what you see is an image from Schatzker's Intertrochanteric Osteotomy book in 1984. This was an AP of the hip, and it was meant to describe some of the particular relationships that you see when you're looking at an AP of the hip. So first, there is a particular relationship that you see between the tip of the trochanter and the center of the head. And in a patient who has what is considered normal varus valgus, then a parallel line drawn from the tip of the trochanter should intersect the center of the head. And that's what they're showing there in that diagram. Second, the distance or the radius of the femoral head, so that distance, is doubled to get to the tip of the trochanter. So that relationship is standardized. In normal anatomy, it's twice the distance of the radius of the femoral head to get from the center of the femoral head to the tip of the trochanter. Third, there is a very particular relationship between the piriformis fossa and the anatomic axis. And I think you know this, those of you who are doing on-axis nailing are familiar with this relationship, but in your drawing, it should represent that. Fourth, there is a particular relationship between the inferior aspect of the neck of the femur and the shaft. It is a smooth, unbroken curve. And the lesser trochanter, in varying degrees, will come out from that curve. And I say in varying degrees because there's wide variability in the population as to the size of the lesser trochanter. So in and of itself, it is not a measure of anteversion. I don't think you can use it just for that. Now, if you have a fracture of the proximal femur and it is attached to one or the other segment, it can help you with rotation, but the size of it in and of itself can't tell you whether someone has 5 degrees of anteversion or 40 degrees of anteversion. Fifth, there is a particular shape at the superior aspect of the femoral neck coming out onto the shadow of the greater trochanter. And on a true AP view, that particular shape is typically maintained. Now I'm going to show you some examples of radiographic anatomy, just normal variations in anatomy or mild pathology that are going to affect that. But for the most part, when we're looking at an AP of the proximal femur, we're expecting to see a particular shape at that location. You might say, well, who cares, right? Why does that matter what the shape is there? Well, we're talking about pertrochanteric femur fractures. And so if you lose the greater trochanter and you lose the lesser trochanter, and all you're dealing with is the head neck segment and the shaft segment, you need to know what the AP of the head neck segment should look like and whether you're affecting it by rotating the shaft segment. So try to get that in your head. The shape of the inferior neck and the shape of the superior neck actually makes a difference. And lastly, I would say on a true AP x-ray, you've got very little overlap of the greater trochanter and the neck itself. And so as you get more and more overlap of the greater trochanter and the neck, you are either seeing a displacement of the greater trochanter or you're seeing a rotation of the proximal femur. And we're going to go over that in a little bit more detail in just a second. All right. So we have a head that is relatively circular. It is not a perfect circle, but it is relatively circular. And in the most part, you can use that to find your center of rotation. We have a radius. We double the radius to get to the tip of the troch. We have an anatomic axis along the piriformis fossa. We have a particular shape of the inferior neck. We have a particular shape of the superior neck on an AP x-ray. Okay. So remember I told you that they're variables. So the position of the beam is a variable, the leg position is a variable, and anatomy is a variable. So just for a second, I want to talk about femurs that are not broken. And so we're going to say we've standardized the beam position to perpendicular to the table, and the table is parallel to the floor. And we're going to talk about what happens when we start to rotate the leg internally or externally. And so if the pictures are showing up on your screen such that they're blocking the far right-hand side of the screen, try to move those to the bottom, if you will, so you can see both pictures on the far right-hand side of the screen. So what you see at the top is, or on the left-hand side, is what we would consider a normal AP view. This happens to be my femur. After perseverating last night, I met one of the x-ray techs early this morning and got a bunch of x-rays of my femur in different rotations. That's kind of, she thought I was kind of strange. I was blocking my junk though, so you won't see my junk in any of this. So, all right, so on the top, let's go up here. All right, you will see varying degrees of internal rotation of the proximal femur and how that affects the relationships that we see. And so you'll see as you get more and more internal rotation, the proximal or the superior neck shadow changes slightly into more of a U. But in addition to that, and probably easier to figure out than an intact femur, is you get less and less overlap of the greater trochanter on the superior neck. So you're seeing the neck en face, if you will, perpendicular to the neck itself. And so you're getting less and less overlap of the greater trochanter on the superior neck. You're also seeing, as you would expect to see, lesser trochanter the more internally rotated the proximal femur gets. The shape of the inferior neck stays very similar, though. There's not much of a difference. And overall, the relationship of the tip of the trochanter to the center of the head is similar. Now, as you get further and further away, it changes. And so we'll see that in some of the external rotation views later. All right. So at the bottom, what you're going to see is externally rotated views of the proximal femur. So you see further and further external rotation. And again, what you're going to see is more overlap of the greater trochanter on the neck the further external you go, such that it gets to the point where you don't see any neck at all. It's the greater trochanter that's abutting the head. In addition to that, you start to see a different shape of the inferior aspect of the neck than you did before. Well, that's a terrible drawing. So it becomes more of a C, as you externally rotate, as opposed to a smoother line, a smoother elongated curve in a true AP view. Okay. All right. So this matters. The rotation of the proximal femur, the leg position, is going to matter. And so the neck shaft angle has the potential to vary with internal and external rotation of the femur on the table. So you need to have some understanding of what is moving together, if it is, and you need to have some understanding of the shape of the proximal femur, particularly the head neck segment, when the greater and lesser are gone, because that is going to change. And if you're just using the angle to define what's right, you may get into a little bit of trouble if the proximal segment isn't in the correct rotation. And if you're just using the tip of the trochanter to the center of the head, again, you may get into trouble, because we know that varus valgus, the appearance of it changes based on the rotation of the femur as well. All right, so we know what the neck shaft angle is. We try to match the contralateral side, but we have to recognize that rotation or the position of the limb has the potential to affect that. And if the limb is not rotating together, the position of the fragments have the potential to affect that. All right. But it's not just the rotation plane, the axial plane, that makes a difference. It's also flexion extension. So I want you to take a look at these images, and I want you to tell me, if you can, which one's which. So think in your head about what you would expect to happen if you had slight flexion of the limb or extension of the limb. I have to admit, I didn't understand this very well, and I was in a session with some people who are really good hip surgeons, master hip surgeons, and they were talking about malreductions, and Keith Mayo piped up and said something about the shape of the proximal aspect of the neck and why it was like that because of the malreduction. So looking at AP, you had the ability to judge the sagittal plane. So at the top, what you'll see up here is a flexed view of the femur. And so this could be just a flexed view of the proximal segment. In this case, the femur is intact, so this is a flexed view of the femur. So you'll see there's a flatter relationship at the superior aspect of the neck. You don't see as much of the trochanteric fossa. The opposite is what you see below. So this is a extended view of the proximal femur, and you get much more of a deep C. You see the trochanteric fossa a lot better. You also see that it changes the relationship of the tip of the trochanter and the center of rotation of the head, right? So in the bottom, in an extended view, it's going to look a lot more varus than in a flexed view at the top. All right, so the position of the limb or the position of the fragments is going to have an effect on your ability to judge whether you have an appropriate reduction or not. And that's why that project was so complicated, because cases differ. We have different pieces associated with some pertrochanteric femur fractures than others. We should be looking at different things, but we have to have an educated gestalt when we're going into it, because if all we have is the head neck segment and the shaft that is really moving for us, we need to know what those should look like compared to each other. All right. So you may look at this and say, well, crap, neither of those are reduced, so what does that matter? But this is an article that was published, and it's so complicated, I can't understand it. These guys are way smarter than I am, out of Harvard. And they show the difference in flexion and neutral with the same reduction, the implant in the same position, but the difference in the radiographic parameters that you'd be looking at. So what they were trying to show is that flexion and extension of the proximal segment can have a significant effect on your ability to judge varus valgus. If you look at the top right, your neck shaft angle looks totally different than the bottom right, even though the wire is at a specific angle to the implant itself. They're designed that way. It's a fixed angle device. And similarly, the tip of the trochanter is at a very different relationship with the center of the head at the top versus the bottom, right? So the flexion extension is going to make a difference for you when you're getting these x-rays. So you have to think about it. I'm not going to say it's easy to understand, but I'm saying you have to think about the position of the limb and the position of the fragments and the shapes that you're seeing of the head neck segment and the shaft. All right. Now we've talked about beam. We kind of left beam out because we're going to standardize that at least at the beginning. We've talked about leg position, both in internal and external rotation, and how that affects the AP X-ray. Now I want to talk about variation in anatomy a little bit. So these are 3 uninjured femurs, but what you'll see starting from the far left is an extended lateral epiphysis, which is what we see with some forms of femoral acetabular impingement. So we've lost the round shape of the femoral head, which changes the shadow of the superior aspect of the neck. You see coxa vera in the second diagram. So the center of rotation of the head is below the tip of the trochanter, and you see coxa valga in the third diagram. The center of rotation of the head is above the tip of the lesser trochanter. So these are abnormal anatomy, granted, but these are variations, and we're going to see these things when we're operating on patients that are older that have arthritis, especially the 2 that you see on the left. And so understanding what's there will help you see more. It may not help you get all the reductions right, but it'll certainly help you see and understand more. All right. So we talked about parameters that were normal and things that we were going to look at, shapes, relationships on the AP X-ray. Now it's going to get harder. So I want you to draw a lateral hip X-ray. I'm going to give you a minute to do that as well. We're going to get to cases in a second, I promise you, but I thought it would be kind of unfair to get to cases without doing this as an exercise first. So the effort of doing this requires you to do 2 things. One, it requires you to know what your standard lateral hip X-ray is. I'm really interested to hear the faculty's opinion on that once we get it to the cases. So it requires you to know what your standard lateral hip X-ray is, and it requires you to know what the normal relationships of the proximal femur are on that standard lateral hip X-ray. So once again, beam and rotation make a difference, as does anatomy. All right, so I think you've probably had some time. So this is an example of a lateral hip X-ray, and I want us to spend some time with it for a second. So I have to admit, before that project and before the design of a new version of an implant, I really wasn't thinking much about the standard lateral that I had in every pertrochanteric fracture nailing procedure. In fact, it was variable, and it was purposefully variable because the insertion guide for the device wasn't radiolucent, so I couldn't see what I was trying to see in a true standard lateral, which is what I'm trying to represent here. So let's talk about a standardized lateral for the proximal femur. So there is going to be a collinearity between the head, the neck, and the shaft on a standardized lateral. All right, now once we get that collinearity, there's some things that we can look at, okay? We can look at the shape of the greater trochanter, and I will tell you, it is variable, but if you follow it, it is typically a little bit higher in the back, overlapping the neck, coming down to a curve posteriorly, and meeting the shaft, okay? Now, in perch oak fractures, the greater trochanter is often multifragmentary, and so this is difficult to assess, and it may not be in line with the head, neck, shaft collinearity, which creates problems when your starting point is not on the greater trochanter, right? So I want to think about that for a second. All right, after you've drawn the greater trochanter, you can draw in the posterior neck shadow, which is confluent with the lesser trochanter and shaft and posterior medial buttress. And this is something that's actually pretty useful for me, at least intraoperatively. Now, many of the perch oak fractures we have lesser trochanteric or posterior medial buttress compromise, but that overall shape is helpful to draw out, or at least to think in your head when you're looking at the lateral to see if you have things reduced or not. Now, the last one I'll say I find extremely hard to be able to get on a true lateral x-ray with collinearity of the head, neck, and shaft, and that's the anterior neck shadow, because it gets mixed up with the greater trochanter there, and I have a really hard time figuring out exactly where it is. Now, I'll talk to you about some tricks in order to see that area better and about why that area is so important in just a second. And at this point, I'm using more than one lateral intraoperatively. I'm using this lateral and another lateral in order to be able to see that anterior neck shadow a little bit better for the reasons that we'll talk about in a second. All right, so collinearity, standardized x-ray, head, neck, shaft. Sphericity of the head is usually reasonably preserved. Shape of the greater trochanter, typically a little bit more proximal as you get more posterior, with a special bump as you get posterior closer to the lesser. It's a wide structure, very different than the piriformis fossa, which you can clearly see there. This is one of the reasons that many of us like piriformis fossa nailing as opposed to trochanteric nailing, because there is a clearly defined point that we're going for on an x-ray on piriformis nailing as opposed to this. All right. Posterior neck shadow, confluent, I think that's really nice to use. Anterior neck shadow, compromised by the greater troch in this perfect lateral x-ray. We'll talk about some other ways to see, okay? Now, once again, we're gonna talk a little bit about variables. I wasn't okay with getting my junk radiated in the lateral view like this, and so I took a model and we went through some rotations on the model to go from what would be considered sort of a standard collinear lateral to what you see at the top, which is going to be variations in coming from internal rotation out towards neutral. So this is going to be far internal rotation coming towards neutral, moving to external rotation to further external rotation is what you see here. And so you'll see the relationship of the greater trochanter is necessarily going to change, assuming it's intact, to the neck and the shaft. And you can see how it would be really easy, if you didn't standardize your lateral, to start at a point which was not in line with the neck and the shaft and in the central or reasonably central portion of the greater trochanter, right? So collinearity, useful standardization of a lateral x-ray. All right. So this is what I was talking about earlier about the problem with standardization of a lateral x-ray to collinearity is the trouble seeing the anteromedial cortical support reduction in unstable pertrochanteric fracture. So if we say patient has a highly unstable pertrochanteric fracture with lesser trochanter and posterior medial buttress involvement, and the anterior aspect of the head and neck does have a spike which matches the spike on the shaft fragment, albeit small, that may be the only point at which you're going to get load sharing with these sliding devices. So by keying in that anteromedial spike, theoretically at least, we should have less sliding, which leads to less deformity and less potential failure, right? Because we're getting load sharing earlier. And so by having a slightly externally rotated lateral, it allows you to uncover that anteromedial spike from the greater trochanter, the anterior aspect of the greater trochanter. And so those are the two laterals that I'm typically using when I'm trying to fix these. And once again, when we're in the operating room, we're doing it this way though. And so my experience in training was there was a lot of manipulation of the beam and of the leg without me understanding exactly what was happening. And with them both being variables, that gets really dangerous. And so I would encourage you to set standardization for your lateral x-ray at some point and to understand what that is with respect to the beam. Because if you continue to move either the beam or the leg or both, the operating room can be a very confusing place when you're trying to understand whether you've gotten a reduction of a per-choke fracture. Right? Now, there's another plane to talk about, and I think this is especially useful when we're talking about proximal femur fractures and femoral neck fractures, and that is this plane. And so if you're going for a true transverse lateral, you're going to get a lot of overlap between the greater trochanter and the head, and it's really going to block you from seeing the neck. So the more obliquity you create with the C-arm, the better you can uncover the neck from the greater trochanter. And this is actually possible now, and oftentimes will, with the guides that we have available now for insertion, oftentimes they will not be in the way when you try to create more obliquity like this. It allows you to see things a little bit better. And so recognize that in the same rotation, you can uncover more of the neck by changing the obliquity of the C-arm to the limb. This is very helpful when you're dealing with proximal fractures. All right, so we talked about lateral position, beam, or excuse me, lateral radiograph, beam, leg position, and now we're going to talk about anatomy. So I think it's ridiculous to try to think we're all going to understand the axial and sagittal plane anatomy of the proximal femur in this lecture. I don't still, after 15 plus years. It's very confusing to me, and I've read a lot about it, and I think a lot about it. But I want to show you what's out there in order to understand why sometimes, if you're getting that standardized lateral view, you can't seem to get the wire parallel to the neck in the center of the head. So this was written in Tonus's book on congenital dysplasia of the hip back in 1987. It's a really interesting book. There are parts of it that are exceptional. It's probably not out anymore. It's a Springer Verlag book, and they unfortunately put away a lot of their books prior to their prime, I would say. But if you can get your hands on it, it's useful to look at, just like Schatzker's intertrochanteric osteotomy, especially if you're going to spend your life doing proximal femur osteotomies or fracture fixation around here. So I want you to look at A through G, and we're going to talk about appropriate nomenclature for this. And it should help you understand why the lateral view is going to change, okay? So A, what you're seeing in A is normal anatorsion of the femoral neck. And so we consider that to be approximately 10 to 15 degrees, and that is the relationship of the posterior condylar axis and the axis of the neck. That's normal anatorsion. In B, what you're seeing is something called anaversion of the neck with normal anatorsion. So version of the neck is described by Tonus, and I think he's probably the foremost expert on this, as the variation in the relationship or the angle between the neck and the head, okay? And so you've seen C a lot, right? So what do you expect in C, right? That's skiffy, right? That's retroversion of the femoral neck or femoral head, basically, with normal anatorsion of the neck. So this will tell you why you could possibly end up with a wire that seems to start in the central aspect of the neck, be parallel to the neck, and not be anywhere near the center of the head, or a wire that gets to the center of the head with an appropriate starting point in the greater trochanter, but for whatever reason can't go parallel to the neck, because there's variation in the proximal femur. In D, what you're seeing is excessive anatorsion of the neck, and in retrotorsion of the neck is what you see in E. And then these are called anti-flexion and retroflexion. And I think I'd cry if I saw something like that in a trauma case, because I wouldn't know what the heck to do to try to get implants in the right position. So just recognize there are variations in anatomy that can complicate your ability to get the implant exactly where you think it should be, even if you feel like you've done everything right. All right, so we can take a case like this, and we can say, all right, this is this patient's normal. This is a standard collinear view of the proximal femur. And we can see not only does he have a flexion deformity or a retrotorsion of the femoral neck, he also has a retroversion issue of the femoral neck, right? So this is a patient that had a slip capital femoral epiphysis that there was an attempt made to fix him with a Southwick procedure, which is subtrachea osteotomy. It failed. So he got a double deformity. But you can figure that out if you understand what normal anatomy is supposed to look like. And the other side is super helpful, as you see here. All right, now we're to cases. And I'm going to get the faculty involved because I'm interested in how they're doing these, because I'd love to figure out ways to improve my practice. But we're going to start with a real simple one. So this is a puffball, but there are going to be some questions about it that will go past sort of the puffball nature of the case. So here's a proximal femur fracture in an elderly patient. This is the one I showed you at the very beginning. I didn't know this was going to be a puffball, right? And that's one of the things I'm going to talk to the faculty about. But what would you do? What would your plan be for reduction maneuvers at the beginning of this procedure? And how are you going to judge your reduction? So you already figured that out. That was something you wrote down at the beginning. And so I want to show you what happened. So here's traction, right? Okay. So if we talk about the things that we're going to look at in terms of our ability to assess reduction, we talked about the relationship between the tip of the troch and the center of the head, assuming the greater trochanter is moving, right? We talked about the neck shaft angle. We talked about the relationship of the piriformis and the anatomic axis. We talked about the shape of the inferior aspect of the neck. And we talked about the shape of the superior aspect of the neck. On the lateral, we talked about collinearity. We talked about this unbroken line, which is broken because of the posteromedial buttress, but you can see it's still reasonably smooth. And we talked about the shape of the trochanter, which also is a little bit different because the trochanter is broken in this case. And we talked about the anterior neckline, which seems to be reasonably intact. All right, so that's just traction. Now this is traction and internal rotation. This is traction and external rotation. This is traction, internal rotation, and adduction. I'm going through these fast because ultimately it doesn't really matter. So nothing's changing. These fragments are moving together. Once traction was created, somehow they locked in well enough in order to allow for rotation not to create a deformity. Same with adduction. So for the faculty, and we can just start with you, Tom. In my residency, I don't think there was a standard reduction sequence. In fact, I felt like it was just a little bit of voodoo going on. I'd walk in and somebody would just kind of, mess with the foot and the traction, and all of a sudden they'd say, yeah, that looks okay, right? So do you have a standard reduction sequence that you do with all per-troch fractures?
I guess, to start at the very floor, it's boot traction for old people. I do it on a traction table. I don't do it with that flexed, externally rotated contralateral limb. I do with the contralateral limb extended,
yeah,
the hip, scissored, if you will. And then,
what does that help you with?
I think it helps me struggle less to get a good lateral.
Yeah, I think it seems to help me level the pelvis too, to where the pelvis doesn't tilt and they don't sag as much on that side that we're operating on. Because I've gone to that too, and there's some safety measures associated with it as well in terms of well-let compartment syndrome and perineal palsy and all sorts of stuff. So I'm with you on that one. What else?
And we kind of jury-rig the old OSI traction table to work not the way it's intended, but put the boot upside down on one side, and that's your extension side. You will occasionally run into some old person with such a stiff, well hip, unbroken hip that they don't want to do it.
Yep.
And I've struggled on that, but that's pretty rare. And then I think I go longitudinal traction, then external, then likely some internal rotation. But as you know, if you're going to malreduce this rotationally, you're more likely to internally rotate it. But that's probably my sequence. And then lateral pressure, depending on what the fluoro looks like after the first two moves. Yeah.
Mike, you any different?
Yeah, the only thing I'd say, I know you flipped through a bunch, but can you go back to the injury lateral?
Yeah.
So I kind of start the same. I start with traction. And then, interestingly, I think it's pretty common and it's hard to see. So this isn't the best lateral, but the common fracture line, but you can actually see, but this common fracture line is actually like in the semi-coronal plane, going from proximal posterior to distal anterior. And then the shaft rotates externally, right? So you're looking like at the fracture line on FOS. And so on good laterals, so that's looking at one of the planes of the fracture. It's a hard fracture to figure out. So what I found is often traction can you hear me? Do I lock up?
Yeah, I'm good.
Often traction will lock that fracture line into place. That's often not in the right position. So it's hard to assess that. And I think it's hard to reduce that like obliquity, basically. So I'll pull traction, and, like Tom said, you can often make the fracture line on the AP look better with internal rotation, but you can over internally rotate and not realize it radiographically too.
100%.
So as far as to get to your question on sequence, I'll pull some traction and I'll try to jiggle the rotation just to unlock that that oblique plane fracture line. And just, often these need kind of an A to P clamp, which I don't do too often. And so as far as sequence, that's about it. And then the sequence follows based on what it needs. So sometimes we'll get a hook over the calcar or a ball spike laterally or anteriorly.
All right. Sean, anything different?
I don't think much to add other than we do these free-legged. And just because it only takes a few minutes, actually, usually, as mean as it sounds, even in elderly patients, we'll just put in a distal femoral skeletal traction pin, which will obviously be removed at the end. But I think the reduction sequence is no different than what Thomas and Mike said. The one thing I will say is the number of times, and that's why I'm mesmerized by your talk thus far, Matt, the number of times that I do a pure closed reduction is quite small. Now, I'm not sure that I'm changing outcomes, but they are usually getting from a percutaneous to a larger incision with some type of help, because I'm rarely satisfied with the reduction I get purely with traction and internal rotation. But I can't give you any consistency, and I'm hoping you're going to tell me so that I can do these a little more efficiently.
I wish. You guys are the only ones I see on the call. Is that correct? Are there any other faculty on here? I don't want to leave anybody out.
Hey, Matt, it's Paul. I just got in late. Sorry, a lot going on. You guys are saying great things. The only thing I might add, because I basically learned from you guys anyway, is I have my guys, traction is key. You guys get that, but I also don't do it on a traction table. I do it free-legged. I will use either weights or a Shands pin or just a free resident. But the one thing we've been doing with some success is marking out, especially for a recon nail, where the recon screws are going to go, making that incision, elevating the lateralis. And usually the fracture's in that area, so you don't have to make a separate incision.
Yeah.
You get some pretty good clamping or collinear clamping or something in there. So at the end of the day, you didn't have to fillet the whole femur. It looks like you kind of did it like you normally would, but you kind of worked through that window you were going to put your recon screws in.
Yeah, that makes sense. So guys, are there any fragments that rarely move with the traction table or with traction in general? What do you think? We always talk about, traction is useful as an indirect reduction tool, but something has to be connected to the fragments that's connected to the distal segment in this case. So if you're pulling on it, it will move, or the distal segment has to be abutting the proximal segment or this fragment such that when you pull and rotate, it moves those fragments as well. So, for me, like posterior fragments of the greater trochanter don't go anywhere. I can pull as much as I want and I can't get them to go anywhere. And I haven't really figured out any way to hold them in place reasonably. So I usually let them fly. So I'm curious, how about you guys?
Yeah, same. I agree.
Yeah.
And then, it's interesting, and you alluded to it a bit, like, so this lateral hip view, which is essentially a lateral neck view, if you go back to one of your fluoros, like, you know, honestly, it looks pretty good to me, and
Yeah.
I would probably be close to happy. But when you go to a true like proximal femur lateral that doesn't account for the anteversion of the neck,
Yeah.
it's just amazing how this lateral view, which looks everything you said, lined up, posterior cortex, flat to the floor, you'll see something way off on the medial side. And so there's some fragments on the medial side that seem to be not moving with traction either. And it's amazing how different it can look with a little bit different rotation of the beam.
Yeah, we're going to talk about that in the next case because I think that's really, yeah. Tom, what do you think?
I don't want to throw the discussion into chaos, but you said we're going to standardize the beam. Would you operate on that image on the right?
Yeah, I did. So that's one of the
I
things.
mean the reduction, I mean the image. Would you use that image to operate?
No, I would use that to judge the reduction. That's the over-rotated lateral that I was talking about before in order to assess the reduction. But if I wanted, assuming it's all moving together and the posterior aspect of the greater is moving with it, I would want a slightly more internally rotated view so that I would know exactly where on the greater I should start to be central with the neck and shaft. How about you?
Same thing. And I, you know, it's like, I think we have pounded for years on like where your start point should be on the AP. And now the ones of these that I have to revise, I find that the whole is, I can't draw on a screen, but the whole isn't just too lateral. The whole is also too anterior. And that's because they operated exactly on this view and they thought they were in the middle, but in fact, they were on the front of the troch, right?
Yeah, right. All right, so.
That's not changing the bone, that's changing the beam.
Yeah.
Okay.
So what do you do in cases where it appears that the greater trochanter is posteriorly displaced and it's not moving with rotation?
I don't do much, honestly, specifically. You know, if it's that comminuted, then I kind of bridge past it, nail through it, kind of thing.
Yeah.
I think I put a malleolar clamp in the A to P plane, but when you take the malleolar clamp in the A to P plane off, that frag does whatever it likes.
Right. Yeah. So do you feel like you can predict the need for perk or open reduction based on the injury films?
No.
I can't.
Yeah. You know, apart from the like 31A13, you know, the one where there's so much displacement, and those are typically in slightly younger patients anyway, like you see it and you know that's going to be a cluster. Like I can't, on these typical pertroch fractures, I can't assess when I'm going to need perk or open, but we do them all in the same manner. We are using a fracture top table. These are elderly. We are using a fracture top table, and we transition from closed reduction to, you know, percutaneous to open based on needs. I guess that's similar for all you guys. All right, let's get a little harder. So this is another one that looks quite similar to me to the one that we just did. All right, so I want those of you participating to think a little bit about your reduction maneuvers. You've heard from the faculty that their standard reduction is typically longitudinal traction and some form of internal rotation. You know, when I was at Harborview, Henley used to always say these reduce better in external rotation than internal rotation. Does he ever tell you that, Sean?
Yeah, absolutely.
I think that's interesting, and I think it's true, and I think it complicates things pretty significantly for me. And we'll show that in just a second. But anyway, all right. So I'm curious, before we go any further, I'm just going to push you guys a little bit further. How do you know when internal rotation isn't the correct answer?
So hard.
Yeah.
There's such a lack of radiographic clues for, I mean, the shaft is almost always externally rotated just because you look at it on FUS, but how much it needs, when it's reduced rotationally based on the fragment appearance, it's hard.
Yeah. Yeah, I mean, it's Sean, Tom, anything? Paul?
Yeah, welcome to my cluster. So yes, I'm constantly obsessing on the position of the beam, the position of the distal fragment, and trying to judge how much version I have now given them, and trying to interpret the multiple radiographic clues that I have. But other than a mishmash of that, I'm waiting for the method.
Yeah, I usually, honestly, like when I'll make a small perk incision, I'll extend it more just so I can palpate the fracture line, just because I'm so curious based on what the leg look like, what the fluoro look like, and what the actual rotation is and whatever. Unfortunately, on a fracture table with traction, it seems like that's often locked in, like it's just, it's tight in there.
You know, I can't.
Tom, go ahead.
Go ahead, Paul.
No. The only thing I was going to say is I like what Mike's saying there and what everybody's saying, because it is hard. I find myself, if I'm maximally internally rotated, that's the only way it looks good. I'm clearly fooling myself. So I do like to open up a little bit and kind of feel in there. Ironically, I don't do any of these on a fracture table. Everyone thinks I'm crazy, but I haven't used a fracture table in years because I couldn't get it right on a fracture table. After a while, too much sag, too much sort of. The only person happy on the fracture table was my X-ray tech. And let's face it, their job's to torture me. I don't care if they're happy. So I went everything free-legged and with a bump so I could kind of get a better feel.
Yeah, and when I can't make out the lateral all that great, Gravy, but like when I see this, my immediate thought is I'm going to have a problem, not with this usual suspects of the head, neck segment and the greater troch segment, but also the shaft is going to drop under gravity. And I'm going to have to put something. There's zero chance you're just going to pull on this and nail it.
Yeah.
And just one of the thought that I had when PG was talking about not using the traction table, one thing that I had to learn the hard way early on was sometimes when you're just starting in practice and you do use a traction table, and you can't get it reduced, your mental move is, I need to add traction. If you keep adding traction and it isn't working, you're only making it worse.
Yeah.
And then one day you realize to take the traction off and it actually starts to get better. And that's when so if traction isn't working, more traction, rarely the answer.
Good point.
All right. How many of you getting contralateral templates?
Not in everyone, that's for sure.
Yeah, great.
So we've started doing it more because I was having trouble understanding it, just trying to study this and understand it a little bit better, because so often the lesser and greater aren't helpful. So we're looking at the shadow of the neck and we're trying to figure out what that head neck segment should look like. So I'm going to show you that, and I'm going to show you pure traction as a comparison to the contralateral side. So are you happy with this on the AP?
No.
Okay, why not?
Because on the AP, just got that dark density about down by the lesser troch tells me something's just not quite right. I mean, the greater troch will always fool you, but if you look down medial and towards the lesser troch, there's too much density going on there. Something's overlapped. This is that one that could be 100% off in the lateral. You don't realize it, so you get a lateral in the high energy inner trochs. Those are the ones that really can fool you.
So this is traction and internal rotation. So these aren't moving together like the last case. There is some abutment. You can see the shape of the superior neck seem to flex, but they're not moving together completely. And you'll see that traction and external rotation, there seems to be a little bit more movement. Adduction, traction, internal rotation, adduction, which is the test answer for how to reduce these. I think that looks like a monkey's ass. Traction, external rotation, and adduction, which doesn't look much better than just the initial traction that I had, I would argue. So here's a lateral x-ray. So in that scenario, I felt like things weren't reducing through closed manner, and I felt as though I needed to help. And so I made an incision as you described and put a cob over the top in order to try to posteriorly translate the distal segment. If you have a gap anteriorly that you see on the under-rotated view, then either lifting the foot in order to change the sagittal plane alignment or internally rotating the foot will close down that anterior gap, according to the study that the AO did. And I think that's interesting, and sometimes it works, not always. When it doesn't, I typically try something like this. So I'm looking at the under-rotated lateral. If I see an anterior gap, or asymmetry, then I try either elevation of the foot or internal rotation of the distal segment. That doesn't work, then I'm looking at some reduction maneuver like this. Interestingly, you'll see that the lateral that we got postoperatively was not consistent with the one that we got intraoperatively, which once again shows sometimes you think you got it right and you didn't. So you see that displacement much more notably on that lateral that we got postoperatively, which is just a little bit less of a rotated view, right? So that's where you see the anteromedial neck better. So
It's
because of
interesting
that,
right?
yeah,
I mean,
yeah, for sure.
but it's like to close the fracture line, either flexion or internal rotation, but it's like, what's the deformity? You know what I mean? It shouldn't
Yeah.
be both of those can solve a single problem. It's either one, either it needs rotation or sagittal plane correction.
Yeah, it's just hard to know which one it is, right?
Right.
So I try
yeah,
one,
that's what I mean.
if it doesn't work, I try the other. If it doesn't
I
work,
gotcha.
I'm making an incision, you know, and a lot of times we just accept it, which is probably wrong. And I think that's why we're getting more collapse than some of what is reported. So I'm curious, are you guys using the same lateral radiographs that we've talked about so far, or do you have something different that you do? And at what point do you standardize the lateral and not change from it anymore?
Yeah, I guess like I mentioned, I like to check a full flat, like proximal femur lateral, but it's disheartening because it doesn't really correlate to what I think is happening usually. It really looks very different from just 15 degrees different from a neck lateral.
Yeah.
But I check it and just see if it's all lining up.
Tom,
Mike, when you say it looks different, is it like, do you find that you got translation of the shaft, or what do you not like?
So what I find happens a lot is on a neck lateral, everything's collinear and there's no apices. And then you come full flat and you see the version of the neck and there's an apex from the proximal fragment. And whether that's flexion or external rotation or medial translation, not always clear to me. It seems like it's something, a little bit of each in different situations, but
I think something you super can't account for when you get that, the lateral that you want to operate on is rotation of the neck.
Yeah.
Right. And then when you were talking about when the neck is right, you've got that slope between the head and the cranial neck is just right. You know when that's wrong, but you don't know on the lateral.
Yeah, I completely agree. I find it incredibly hard to understand. And that's what makes me so interested in this topic. I would imagine, and I talked to PB about it, you know, if we did CT version studies on these patients post-operatively, I bet our rotational malreductions are substantial. And I bet that is consistent. But his point was, well, nobody's going to care. They're not going to publish that. And I think he's probably right. You know, I mean, in this population, people aren't talking much about this problem. And I'm not sure they would really feel like it was worth it. But I feel like we don't completely understand. And I feel a little bit better from talking to you guys because I'm not the only one who's dealing with some of these issues. I will, yeah, go ahead.
Even in an old person, when you get outside a certain range.
Oh, yeah, for sure.
And you know, like people have made this argument, like the hip fracture is more important because they got no reserve. Like if you spin an old lady in 20 degrees, she's done walking, period.
Yeah, it's interesting, right? So I will say, you know, this at what point in the procedure is it important to standardize placement of lateral? For me, at least, starting point and entrance angle. So I have to have that collinear view, just like Tom described, when I'm trying to define the starting point on the lateral. Otherwise, I don't know where I am with respect to the neck. And so are you guys all using that for the starting point on the lateral?
Yes.
Yeah. Okay.
Yeah. And man, I just got to add, I don't want to take you off topic, but your points are great. I mean, this is one when you were a resident, people thought they tucked away, and now it's a matter of how fast you could do it. And can I do it in 8 minutes? Can I do it in 12 minutes? But you guys are students of the game. You guys are inventing the game. And I got to say to the group, you got to appreciate how much we still don't know, despite you talking to a bunch of people who do a lot of them.
Crazy, right? It's kind of embarrassing, really, when you think about how many we're
to
doing.
Your credit that you won't give it up. I mean, you realize this is not solved. I mean, you know, you ask a community guy, it's like, yeah, you know, short nail, 15 minutes or less, throw it up on the table and try and rotate it, you're done. And you guys are having a great discussion about how that's just not okay. That's not enough. I mean, Higgins just said, grandma's never going to walk again. And everyone thinks they've done something good. That's not good.
All right, let me show you worse then. So the last one. Let's save the best for last. All right, so this is your fracture pattern. Same thing. What are you going to use for reduction maneuvers? How are you going to judge your reduction? So for me, there's no real greater trochanter. The lesser troch and posterior medial buttress is off. There's arthritis of the hip. There are signs of FAI in terms of the head-neck junction. There's some anterior fragment that I'm seeing on the lateral view, and it's another crappy lateral, and it's really difficult to assess, but it bothers me. All right, so once again, we got the contralateral side. This is an AP. This is what the AP of the head neck should look like at the end of the procedure. All right, everybody with me? Traction. Are you okay with this? And what's your next move if you're not?
So no.
No, yeah.
All right,
And
which part?
the funny thing is, you said something funny earlier. You're like, when you pull traction, you're only pulling on the shaft. Like, you're not pulling on the other three pieces.
Yeah.
Interestingly, in the wicked arthritic old lady, like, the head neck's immobilized.
Yeah. Yeah.
Right? It's not going to free rotate on you because it doesn't rotate anyway.
Yeah.
But I used to think, well, maybe that's an advantage, and it's not. It gets harder.
Yeah. So
Did I answer any of the questions?
So, I mean, I appreciate the way y'all are skirting past the what's the next maneuver. So, for me,
I think you got to open it. I mean, let's stop playing around.
all right.
Closed is not going to get it. Now, I won't go into how I'm going to open it, but I'm going to open it enough to be able to get to that medial side, get posterior, and get anterior a little bit and see what's going on.
So
and no one ever wants to play.
You got to explain it. So you're trying to feel over the anteromedial side of this fracture to see if you can key in this spike here. Is that fair?
It'd be that posterior medial spike, which, you wouldn't normally go anterior for because it's counterintuitive. Sometimes you can get to by coming over the top.
Okay.
Because you can't just keep pulling and twisting. You've got to get control. It's kind of like a femoral neck. You almost got to get control of both segments before you think you're going to get a reduction. You're not going to you almost got to make them independent. So get the shaft or whatever's left of the shaft away from the neck, put the neck where it should be, and then put the shaft where it should be.
So
it's hard.
I felt like I had lateral translation of the shaft. I felt like it needed to move that way in order to restore that medial femoral neck shaft confluence that we're seeing on the other side. I felt like the shape of the head and neck looked reasonable here compared to the contralateral side. I felt like the location of the tip of the troch was, if anything, a little bit valgus compared to the contralateral side. I saw this gap too as a problem, but I figured that it was either partly rotational or partly secondary to the fact the posterior medial buttress is on this lesser trochanteric fragment. And so that's not there anyway. So I thought what I really needed to do was change that. Now, I may be wrong, but that's what I was thinking. So we tried rotation, and it didn't really work very well. So this is when you guys are thinking something lateral on the shaft to medially translate it. Is that fair?
Or something over the top to grab the medial neck and pull it laterally, but the same basic concept. Yeah.
Yeah, one or the other. Okay. All right. So here's our lateral. Sucks, right? Can't see squat. So we're going to redo it. And there's our lateral. See it a lot better. All right, no open exposure.
Doesn't the neck look like it's way too long or something on the lateral?
Yeah, it's distracted.
So doesn't that depend on the beam, though, right? The angulation that you come in with, right? So now we've uncovered. Remember, the grater was smashed, and so I felt as though we had just uncovered more of the neck with this X-ray view.
Okay.
May not be right, though, right? I don't know. That's what... All right, so do you like the starting point and entry angle?
Yeah.
Yeah.
Okay, so I was worried about the instability here, and so we used augmentation. We don't have to talk about that. That's just what you see going on. All right. So what do you think? Tom, would you leave the OR with this?
Well, it has cement in it now.
Come on.
Good point.
I mean, it's a little Varus, right?
I mean, this is not horrible. It's not perfectly correct. You know, when you have this lateral translation of the shaft, I feel like, and doing what Sean mentioned, which I do frequently, is come over the top with a hook and try to pull in the neck.
Sure.
You get more varus that way. It's a little bit of a paradox.
And if you push on the shaft, the only way it's going to stay there is if you put in a blocking screw. How many of you using blocking screws in 80-year-olds?
Nope. Yeah, no, that's not happening.
Right.
But I do like what Sean and Mike are saying about trying to get the neck over with either a hook or a clamp. But I agree, you can overdo it, and next thing you know, it's in varus. I haven't decided whether it's better to leave that sort of proximal segment over the top of the shaft or inside the shaft. Ideally, you want it to line just perfectly up, but it's a question of whether you want it to shear or whether you want it to fall into varus. And believe me, I haven't figured that out, especially if it's comminuted.
Yeah, so is your expectation that this is going to shorten along the axis of the device such that we get some intrinsic stability?
I hope. I think it is going to hit maybe up top first and then slide down on the shaft a little bit and then maybe go a little bit of varus, but maybe heal before it all can go bad.
Okay. So Tom, you said you wouldn't leave the OR with this. You would have. What would you have done differently?
I
reduce it.
I didn't say that. I said there's cement in it.
Yeah.
What about all right, so you're right here. Number of these devices, regardless of brand, have something where you'll spin a knob and it'll try to drag the blade plus the cement now, which is a more sturdy object. It'll try and drag that lateral.
Yeah.
Did you try that?
Very reasonable. We didn't in this case, but very reasonable. I agree with you. And we oftentimes try to do that to try to get some compression intraoperatively. Mike?
I would, if I got to this point, I would leave the OR. I wouldn't try to do more to this at this point.
Yeah. All right. Sean, I'm not going to ask you. I know it's making you sick.
No.
So we commonly use rotation of the limb on the traction table to achieve a reduction. Are there certain cases where you standardize the position of the knee? Or do you always do it? So we say we use internal and external rotation to achieve a reduction, right? So when does that stop?
So I do like to get the knee in a standard position at some point during the surgery so that I can interpret the rotation of the limb that I've created, the anteversion, relative to the implant. However, I find, as you've said, you have to rotate to get it reduced. And that's why I will frequently augment my closed reduction maneuvers with wires or something like that. So maybe I internally rotate. I have trouble interpreting the radiographic views, but I feel like the reduction's better. Put in wires to hold it and then normalize the position of the knee so that I'm relatively patella up and I can interpret the lateral.
Yeah.
So at that point, and then if it's off, I redo.
Any different, Tom?
No, honestly, I kind of stare at the boot on the traction table and where it's pointed. I'm not relying on the knee or on the contralateral limb, to be honest with you.
Yeah.
Yeah, I mean, the benefit of being free-legged on a flat top, like Sean's talking about, is you can do that a little more realistically. Like when you're in a fracture table and the one buttock is sagging a little bit and you're in a boot, it's a lot harder to use the knee based on relative to the pelvis, basically, you know?
Yeah, so I think you guys said that this was okay, right? Which is what I thought too. And then I left the room and I said, just put in distal interlocks.
Crazy.
Now, what do you think?
Oh, that rotation is heartbreaking.
Mm-hmm.
Well, yeah, and you know, it's interesting. If you had used a short nail, you would never even had it.
No idea.
That was like
you would have known that was that way. Yeah.
No idea, right? So this is the post-op X-ray, AP. So now it looks like the proximal fragment is externally rotated compared to a pure AP of the knee based on the contralateral side, right? And if you look at the intraoperative films, it looks like you've got internal rotation of the limb in order to get the AP X-ray that you needed. Interesting.
Crazy.
I mean, interesting in a you suck kind of way, but right? And if
Well,
you
no,
look
but-
at this and you compare it to the contralateral side, you can see like it's different. Something's wrong, right? So,
So Greg, so if you're present when you're locking those, when you're putting those distal locks in, right, you're also going to appreciate that your hand is either doing this or it's doing that, right?
yeah, for sure. So I changed the position of the distal segment at that point, or the nail, in order to get a more reasonable view. Now, I don't know if that's right or not. I'll let you know. I'm going to get a CT version study in order to find out how different she is than her other side. Interestingly, her resting posture didn't seem to be that different from one to the other at the end. And we looked, and her resting posture was like, well, that's too consistent. That shouldn't make sense, right? And so I feel like hip range of motion profile and resting posture in acute trauma is a little bit challenging to understand. And so I'll let you guys know. But I think this is yeah, go ahead.
Maybe do you flex them up to 90 at the hip and 90 at the knee, and
Yeah. Internal rotation, external
does she
rotation.
match there?
I mean, I can't really tell unless it's 20 degrees or more different. I really can't. I mean, I don't think I pick up on it with the hip range of motion profile unless their torsional difference is 20 degrees or more, personally. And maybe because I'm not very good at a physical exam, but I think it's interesting, you know?
Man, I really think to your credit, it bothers you. I mean, it bothers all of us because we're all still students of the game. But I can tell you what bothers me more is the people who tell them it's fine, it'll be all right, she'll be okay. And you rarely get to see these people back enough to realize how much they may be suffering. They go to a nursing home and then they get
Stitches
COVID
out.
nowadays or some shit, but horrible.
Let me know if you have any trouble. Yeah.
Yeah, basically. Sign off on them.
Yeah. So I don't know. I find this interesting. I find this interesting too, right? So this is her lateral view of her hip and her knee. And I would say that this anatorsion is fine, right? But that is not consistent with what I'm seeing on the far right, which is her intraoperative views, right? Interesting. So, yeah, I know. So at the end of this, hopefully you guys have some better understanding at least of population average or normal radiographic parameters and how we use those objectively intraoperatively in order to assess reduction. I think there's still a lot of questions to be answered. I feel like it's likely that we're malrotating a lot of these and we just don't know it. It's seeing us and we're not seeing it. But maybe in the future we'll get a little bit of a better understanding of what's happening, and hopefully at least you'll see things now that have seen you for a while. So any other comments from the faculty?
Great.
Awesome.
That was fantastic.
I love
Thank
Totally
showing
agree.
them.
Yeah.
That's
You're-
great talk.
I'm glad I can help everybody with my screw ups. So
we all got him. Credit to you for showing some of yours and getting us all better by doing it. We all got him.
yeah. All right, guys.
Great.
Thanks, Matt.
Have a good
Thank
weekend.
you, baby.
Thanks,
You guys-
Matt.
Thanks, Matt. Have a good weekend, guys.